There you go.
Do you see it now?
Yeah.
Yep.
Is it in play mode or is it?
It's just in the preview mode right now. Yeah, it's in regular mode. Just as I think if you select slideshow and play, it should be in the correct mode.
Yeah, it is in slideshow. I have two screens and the wrong one is coming up here.
Yeah, this is the preview, looks like.
How about now?
Same.
Yep, we see this. Yep, that's perfect.
Okay, sorry about that. Do you want me to go ahead and start?
I think Roger, were you wanting to introduce?
Sure, I can, Vince, I'd be delighted to introduce you to the group. Obviously, you don't require a lot of introduction. Everybody here knows you. You're the vice chairman at Rush University, and obviously a fellowship trained spine surgeon. It's great to have you this morning to talk about geriatric odontoid fractures. So you received your medical training in Morgantown, West Virginia, your residency, your spine fellowship training, and then you were for 20 years at Iowa University, and you climbed through the rank to the title of a professor of neurosurgery. And I think in 2009, then you went to Rush University, where you're currently the vice chairman, the head of the spine program, the fellowship director. And Dr. Traynelis' practice really focuses on cervical and complex cervical spine surgery for many years. We're all familiar with his amazing work on disc arthroplasty, adjacent level disease in the cervical spine. He's been the president of the CNS, the Cervical Spine Research Society. He's been the director of the American Board of Neurological Surgery, I think, for 6 years. So you've really done amazing work, not only on the clinical side, but also in terms of research and academia. And this obviously then resulted in a great number of publications that testify to your talent and to your passion about cervical spine surgery. So it's only fitting then that we have you today as a visiting professor and speaker to talk about geriatric odontoid fractures. So Vince, thank you so much for making yourself available at an early hour, and we're looking forward to your presentation.
Well, thank you very much. It's an honor. And I'll just get started because I have a fair amount to say and we're starting just a little late. Here are my disclosures. And we'll just start, some of this will be some basic review, but we'll try to be complete. As we know, odontoid fractures can be almost 20% of all cervical fractures. Most of these are type 2. And although we frequently see patients without deep deficits, really about a quarter of them have deficits from the fracture, and most of them are older. There can be a subtype, this Grauer subtype classification, which really has some help. If you're thinking of anterior screw fixation, the type Grauer B is the optimal. And the Grauer C is really kind of like the old type 2A with that little chip on it. And those fractures have been reported not to heal with immobilization if you're going to try that. And now I want to introduce you to Denise. She's a 91-year-old lady, lives independently, tripped on a carpet on Christmas Day and fell. No loss of consciousness, had bad neck pain, went to the emergency room and was found to have a type 2 odontoid fracture. She has hypertension, she's had cataract surgery, her hemoglobin's 11.2, and I'll come back to that, and her neurologic exam is normal. And here's her CT scan. So we have a displaced odontoid fracture, probably a remote old C1 arch fracture. So this is Denise. And she fits in well with the demographic that we see, you know, that this is a problem of elderly people, and it's an increasing problem. And if we look at this over a decade, the mortality for this doubled from 3.4 to 6.8%, and the incidence markedly increased, as you can see with this curve. So other data, looking at the national patient sample here, we have 31,000 patients. And we look at these, and the hospitalization in this over this decade increases for every group, but it increases the most for those that are over age 85. And that's that upper curve on there. So as we know, it's a increasing problem. I did this is about a year ago. I looked at for PubMed articles searching for odontoid fracture, and here's the number of publications. And you see there's a lot of interest in this because there's more and more publications. And in fact, in February of 21, if I would have amortized that for the year of 2021, and I haven't repeated it, but if I would have, there would have been over 100 publications on odontoid fractures last year. And our treatment options are listed here. We can do nothing, we can use some sort of immobilization, and we have some surgical options. And so let's just go through these. There actually is a study on no treatment done by the Cervical Spine Research Society back in the 80s, and it's not surprising that there's 100% failure of fusion with no treatment. And our next option might be a halo, and the success is varied. We know that older patients are much more likely to fail to fuse with halo immobilization than younger patients. And some of this is somewhat dated because most people don't use halos now, but we shouldn't forget the past. We should realize that sometimes some of this old technique can help us in certain situations. But what do we know about the halo? It's not well tolerated by older people. Here's a study where there was higher mortality in the older people despite lower injury severity scores when compared to younger patients. And the difference was the halo. We know there are complications mostly related to pin site, but there can be skin breakdown and pneumonia. So the halo is not so good.
Vincent Traynelis from Chicago.
I'm glad we're not.
Okay, so if we look at this, this non-halo is a collar. So we start looking at the data with the collar, and we lose a lot of these complications, and the collar becomes more attractive. The initial studies, Anderson and Alonso used collars, but if you really look at their work, for 4 to 6 weeks, they had the patient traction in the collar. Traction is a really good immobilizer. So perhaps some of their success was with the traction. But the collar results are somewhat mixed. But does it really matter? So let's look at some AO prospective data. 58 patients treated non-operatively, and NDI and SF36s didn't seem to matter whether the patients fused or not. But if you look at this, 15 didn't fuse, and of those 15, 11 got surgical fusions. And so this was an intent to treat. And so really they didn't matter, but most of these patients had fusions. Same database, looking at it a little differently, looking at treatment failure, defined as death, major complication, or decline in NDI by more than 9.5 points. And then you see at the bottom bullet, what's associated with failure? Well, age, but I want to bring your attention to initial non-surgical treatment, odds ratio for death, 3. And so and some might say that, well, maybe we're selecting who to operate, who not, that's influence it, but I'm not certain that's the total case. And there are more and more publications indicating that non-operative management of type 2 odontoid fractures is associated with increased mortality. And in fact, if we look at the shift in treatment here from 2003 to 2017, it used to be most patients were treated non-operative. Somewhere around 2005, it switched. And now, and this is 32,000 patients. In 2017, 86% of these patients were operated. And I don't really know what you do at your institutions. I guess I should have asked that earlier, but just at the section meeting, there was an argument put forth to not operate on patients. But the reality is these patients are being operated. And so what are the treatment options? So these are older patients now. These aren't the young patients. So we can put in anterior screws, great idea, fix the fractures, spare motion, very elegant. Some biomechanical data when this first came out. I just bring it out to suggest that Sasso's work said that 1 screw or 2 screws, it didn't seem to matter which was stronger. And that may be true in the lab, but I'm not sure clinically. And the reason is if we look at Applebaum series, Andrew Daly published this, but these are really the Utah older patients. So here's 57 patients, and they 57 patients, 57% fused, and they also chose this, well, if it didn't fuse but it didn't move, we're going to call that a stable fibrous non-union. And so so really then that if you look at it that way, you push your stable number up to 80%. And so it does provide some stability, but really fusion rate isn't that great. But I do want to point out that if you looked at the single screw patients and compared them to the two screw patients, the two screw patients almost had twice as much chance of having a stability endpoint. And so despite the biomechanical data, I feel if you're going to use this technique in older patients, you should put two screws in. It's clear, at least in this modest size study, that was beneficial. The problem, of course, is dysphagia. A quarter of the patients needed feeding tubes and pneumonia. And actually, if we're serious about it, pneumonia is the #1 complication of all cervical spine surgery. So we talk about deficit, talk about wound infection, dysphagia. Most likely thing to happen that's really going to hurt your patient is pneumonia. But the problems with the anterior fixation have a lot to do with the bone quality. And there's been a lot of cutout in older patients, and it's led most surgeons to shy away from this in the older population. And that's really my approach too. I think it's a young type procedure. So that leads us with posterior fusions. And so the Brooks fusion is a historical significance really, and now almost everything is screws. The transarticular screws I'm going to talk about a little bit, and I still use them from time to time because they're fast, they're economical, and I think they can be safe, but I realize that that's kind of a dated technique also. If we look at the guidelines data, this is from the CNS AANS committee. They have level 2 evidence that surgical stabilization and fusion, so this isn't an anterior screw, this is posterior fixation, should be considered for patients over the age of 50. So this is level 2, so it's not quite level 1.
Thank you for calling ADP.
It's pretty good.
Please be advised that this and
Now, these are older patients, and so we might wonder, how frail are they? What are their life expectancy? And so we're going to divulge over to this Nottingham hip fracture score. And this was developed in England, and it predicted 30-day mortality for patients with hip fractures. And it's pretty straightforward. It's age, sex, admission hemoglobin, and a mini mental status test, whether they lived in an institution, comorbidities, and malignancy. And this accurately predicts mortality. So if we look at Denise, she was initially treated with a halo. She had severe pain, and in fact, her fracture angulation increased. And here's her variables. She has a total score of 4 of Nottingham hip fracture score, but she doesn't really have a hip fracture. But it's useful data because this second group in England took this Nottingham hip score and applied it retrospectively to patients with odontoid fractures to see if it matched. And in fact, they found that this was an independent predictor of mortality at 1 year. And if your score was greater than 5, you were in a group that was significantly more likely to have a high 30-day and 1-year mortality. And so these scores are of some value because now we have Denise, who's a 4, so we don't expect Denise to go anywhere in a hurry. She's going to be around. And so this is a typical patient, I think, that I'm prone to see. And so I'm going to go and share some of my experience with 93 consecutive geriatric patients and how I do this and some of my outcomes and thoughts on it. Mean age was 78. They're in the hospital about 10 days. And I'm going to say right out from the start, I operate on everybody. So there's nobody that didn't get surgery. And so if we look at the results here, it's not stratified that I'm picking the best patients. I made a decision years ago that I want everyone operated in 24 to 48 hours out of bed, walking, getting them going. So in my 14-month follow-up, the cause of injury in all the patients, but 8 was a fall. They were all motor vehicle accidents except for this interesting patient that fractured in the surf of Puerto Vallarta. And in fact, there's even a publication here from 2005 about there's some way the waves come in here that throw people down, and it's a common place to have a fracture. So if you vacation there, keep that in mind. But I had one patient that came up after a fracture at the beach. Neurologic status 7, 3 of these patients did have severe spinal cord injuries, and another group had myelopathy that I believe probably pre-existed their fall. Maybe it was related to their fall. And there were 37 patients with additional fractures. Here are the comorbidities, which are what one would expect with a group of people of this age. And I had 3 deaths. They were all octogenarians. And they were pretty much pulmonary and sepsis problems. And a couple of them came relatively early. The other patient had a prolonged course and died a couple weeks after presentation. And here are the rest of my complications. And again, we see pneumonia is up there at the top of the list. So what was the fixation used? Well, I did use transarticular screws in 20 of these patients, but I used all sorts of constructs over time, depending on where the fractures were, what the anatomy looked like, maybe the phase of the moon, who knows. Now, a little bit about the technique. I know this will probably be a shock to people, but I don't monitor these patients with electrophysiological monitoring. I monitor them with that C-arm. So everyone has a lead on. As soon as we turn the patient, I have lead gloves on there as well. We're not going to waste any time. Immediately, we're going to put the C-arm on, and I'm going to line that thing up under fluoro. And if it's lined up under fluoro, there's no cord compression. I don't have to worry. So I will use monitoring for certain cases, but not these cases. These cases, the key is that fluoro shot. We'll start with the transarticulars. These have excellent fusion rates shown by a number of authors. There are limitations if you're not using these anymore, especially if residents are here. There's limitations by anatomy. If you have a big kyphotic upper thoracic area, you're going to have trouble getting your screws in. The vertebral artery can be in the way. These are all limitations. This can be done percutaneous, and it requires a stab incision around T1. The key is that you have to know your anatomy. You have to know where the vertebral is. And I'm going to show you that on the CT, but also you have to be aligned because your target is the anterior arch of C1. And if the anterior arch of C1 is, if you're subluxed a little bit, it's going to drag your screw right through the vertebral when you're aiming at your target. And if you do hit the vertebral, you should put the screw in. It'll stop the bleeding, but then you should take them to angio and find out what's happening. And also you got to pay attention wherever you're putting your screws that you really know where you are and you don't stick a screw out to the side like this. And the target for this is the anterior arch of C1. And so you say, well, look at these screws. They're at the anterior arch, but remember that's ventral to really where the lateral mass ends. And so if you looked at the CT on this patient, these screws are too long. Anyway, what you need to do, and I do this also for pars and pedicle screws, is study that sagittal CT and the axials. The 3D I don't think have any value unless you use image guidance, and I don't use that for any of these. You want anatomic alignment, and you want to know the vertebral's safe. And here's 2 illustrations. One's transarticular, but the other is a C1-2 screw. And the point here is the carotid artery is anterior to the arch of C1. And so you don't want to be too far through that bone, or you could be abut the artery. In fact, here's publication from Brad Currier, where post-operatively they see their screw is against the artery, and that made them go and revise it. So the artery is anterior, and that's important wherever you're putting a screw through the C1 lateral mass. And the hypoglossal nerve is also anterior, so we need to keep that in mind. Posterior C1-2 fixation, initially reported by Weill, 100% fusion rate. He uses little plates, and it's a cumbersome, he still uses these plates. It's a cumbersome way to do it, I think. And it's really harms with the polyaxial screws that we think about with this, because that's pretty much how most people do the procedure now. You can put the screw directly in the mass. Some people like to dilate through this piece of bone beneath the vertebral, and feel that you can avoid bleeding if you do that. I don't like the technique. I think the vertebral is just above you. I think there's a little bit of risk to it, but it's certainly a technique that's used. In fact, one of my partners, Rick Fessler, uses that technique. And if we think about it though, like you see that there's just a little shelf of bone you're trying to go through, and you're going to have to protect that vertebral somehow. And that shelf to me is prone to fracture. So I just go right for the lateral mass. And I like to use K-wires. I'm going to show my technique. I don't use a guide. You see, like just in this sawbones, you put that guide in there and you got to think, well, the root's in there. And I can't really see where my screw is going in because I've got all my equipment in the way. And the screws even, the drill's a little big. So I can see around a K-wire really well. And so here's how it happens. I set my K-wire in there and I look at this and I project where it's going. I think, well, that trajectory is just maybe a little bit too low. I don't really quite like it, so this maybe looks a little bit better. It's about where I want to go. And then you start, and I do now make a tiny little start hole with a 2 millimeter burr, but you just sit there and you're patient because that posterior cortex is tough, and then all of a sudden you drop. So then I drop, shoot another fluoro shot. And it's easy to go through this cancellous bone, and then you park it on the front cortex. With high speed, light touch, and use your haptics, you feel when it drops and you stop. Shoot a fluoro shot. Now I know that's bicortical screw right there. I expand the hole a little bit with a hand drill and I put my screw in. I put it right where I stopped with that K-wire, and I know I have bicortical fixation. And I'll also say I've never used smooth shank screws. I think it's all, you're fusing the thing. I worry I have 10 centimeters of screw thread at the end, and I've got 15 millimeters in a big lateral mass. I can't get all the purchase, so I use threaded screws, and of course they have to be a little high. But the pars and pedicle screws, you need to know where that vertebral is. You're not going to get a pars screw in this patient, and in fact, if you look on the right pedicle, you're not going to get a pedicle screw in that pedicle either. So you have to pay attention to your anatomy and pick what's safe and will give you good purchase. Pedicle screws are stronger than pars screws, but I tend to use pars screws because early on it's the same trajectory as transarticular, and I like doing the same thing every time. So now I save the pedicle for more bailout. And when Neil Wright presented this translaminar work, I thought it was fantastic. I thought, well, gosh, unless we put in a 50 millimeter screw, we're not going to hit the vertebral. It's really good. I think you still should look at the CT scan, because if you have a really big lamina, you want a big diameter screw. You want to engage that cone of cortical bone around it. You don't need fluoro. You can just, dissect it out, use your eyes. You do have to probe this. I don't probe many holes, but you need to know that you didn't violate anteriorly. And the bifid thing, a bifid screw can be a little messy. And despite this, I have a collection of people that you have put in, the trajectory is wrong here. You hardly have any purchase. Somehow these people got in the canal. So it's simple, but it can be, you can still screw it up. And so I like to examine it. Here's how it should look. You should be engaging those cortical rim of bone with your screws. And if you have a bifid one, sometimes for me it's a little messy because you go through sort of it with your start, then you're in an airspace, you start again. So if they're really bifid, I like to just take one side off. I think it's easier. Now I add something else. I'm not sure if everyone does this, but I had a tension band. A number of years ago, I took these 4 articles because there wasn't much out there in the early days of screw fixation. These are articles trying to see what's the strongest construct. And they use different techniques. And I tried to grade them myself with little pluses. So the more pluses I gave them, the better the construct. And what we see here with flexion extension is that the Brooks fusion and the clamps are the best. And that's because they're tension bands, and that's what you need to stop the flexion. And the strength of a tension band is mathematically directly proportional to its distance to the axis of rotation. And so if you put a tension band on the lamina, you're as far away from that C1-2 joint that wants to flex, much farther than when you put a screw right at the joint. And so it does make you stronger. And if you don't have a C1 arch fracture, it gives a great place for graft placement. And so I like to once my screws are in, I'm gonna put a screw, I'm gonna put cable around C1. And what I do is I reverse an O-vicryl suture and I thread it underneath there, pop it off, tie it to the cable. And it's kind of the Sontag, or he calls it the interspinous method. And then I just pull my cable through, drop it around C2, and let's see where we are here. And then I use rib graft. I'm a fan of taking my own rib using an autograft. So it fits right in between there. I've got it shaved down and I tap it in. So it's under just a little bit of compression. And then I can tighten that cable right around it. And here we have it. And there's a little bit of slack in the cable because sometimes they don't make the ends, the force doesn't go around the curve. So you can just put another piece here and I can cinch it up and make the whole thing tighter. So that's how I do that. So I used rib in almost all patients, secured it between 1 and 2 when possible. I also started using C1 to joint fusions, and I'm more and more becoming a fan of this. I place all patients in a collar for 6 weeks, and I look at them at 1 year with a CT scan. And these grafts in the space, you can see them on that CT scan. If we look at this study, on the intact, this is full motion with the force they applied. Injured was an odontoid fracture, so we see it's a little looser in flexion extension, lateral bending. And the S column stands for just putting the spacer in. So if you just put the spacer in, you've decreased your motion to 18% of what it was even before injury. And so it really helps stiffen the segment. It's very impressive to see. And then you add the posterior instrumentation and you get a little more kick for it. So these are osteoporotic fractures. The bone isn't great. And more I'm placing these because especially if there's a C1 arch fracture, it gives a place for fusion. And I think it's an excellent technique. And then here's the reason for the CT scan. This is the same patient, the same day. So I can't be certain on that X-ray that it's fused. And if the screws still have good purchase, it's not going to move. But the CT scan verifies that I have a good dorsal fusion from my rib graft. I talked a little bit about using that technique in the posterior arch of C1 to avoid bleeding, but I think that if you're careful, if you stay in the subperiosteal plane, it takes a little bit of work, and I like to use micro instruments for it, although I don't use the microscope here. But you can see here, as long as I stay in the subperiosteal plane, it's not really going to bleed, and I can bring this down all the way. And what I'm going to show here is actually, we're going to take this root, we're going to put in one of these grafts. I just coagulate it and divide it. I don't tie it. I actually lose more blood, I think, when I cut a root than when I don't. So here I'm working in the joint with the curette. I have some rasps that are going to go in this joint if you haven't done this, or you can use the curette. I don't usually put a burr in there because I'm afraid that it destroys too much bone, but I can, as a reverse cutting rasp, I can clean this out and we'll get a good space for that. And then I put in these machined cortical allografts. You could probably use a little cervical cage. You can use this same technique to help reduce basilar invagination. It's a lot harder. You need to, if you're interested in it, you should start using it on just odontoid fractures, but you can really get some powerful reduction in that C1-2 space. So take the root, pound this graft in, and these are the steps. And then the final construct here. So how did I do? Well, these are the numbers here, and I did great, pretty much, except for this. So here we have C2 lamina fusion rate, 67%, way below all of the others. So that was concerning, and I started looking at it. And here's an example. Here's this lady, posterior subluxation, fix her up, looking good. 1 month later, severe pain, fractures out posteriorly, loses her reduction, requires occipital cervical fusion. And here's some others. Halos around the screws, looking bad. And the initial biomechanical studies showed that this was a solid construct, and it was as good as what we had with our other bone screw choices. But it's just acute testing, and also it's in line with axial rotation. That screw's in line with axial rotation, and a number of subsequent studies, including one by Dr. Hartle here, shows that it's just not quite as good as what we thought. Perhaps one way, if you really have no other point of purchase, one thing to consider would be this technique from the Miami group, where it's really bicortical fixation. And originally this was developed by some pediatric surgeons who were concerned about whether the screw was in the canal. And so it's a good way to know your screw's not in the canal. I've done this on a few occasions. It seems very solid, and it may well be the answer if this is the only place to get fixation on C2. So let's get back to Denise. I failed to tell you, Denise already had a C2-3 facet fusion just spontaneously. So it gives us another place to get some purchase points. And here's our screw. Here we are with Denise lined up. And what about her fracture? Well, the World Health Organization defines this as truly a fragility fracture. And patients with these are twice as likely to have another fracture. Once you have one, you're in trouble. And if we look at what's the most common relative risk for type 2 odontoid fracture, it is osteoporosis. There are some odontoid cysts that can occur in some people, and these seem to be associated with odontoid fractures, but it's really osteoporosis. And at Rush, and I think this important thing that we often don't think about is, we want to fix this fracture, but this patient's going to go home and now break their hip or do something else. So we have a fragility fracture service. Everyone gets evaluated immediately. Most of these patients are diagnosed with osteoporosis, and there's just a whole host of tests that are performed, and DEXA scans are obtained, and so these patients are worked up and treated. And I think this is a big service to our patients, as big as fixing them, because they all end up on therapy, and I'm certain that there's a certain group of them that has prevented a second fracture. So if you don't have that sort of system, I would encourage you to explore it. The internists that are interested in bone would be more than happy to help you, I'm sure. Now, what happens to the fractures? We have fusion rate. We want to know what happens to this fracture. Again, the Utah group showed in all comers that, especially young people, that a lot of these people heal the fracture. But this group in Shanghai has done some fantastic work. What they did is they looked at posterior temporary fixation. And these patients are average age of 42 or 40. But they put the screws in. They got a CT scan in several months. If there was fracture healing, they took the screws out. And the patients did pretty well. And here's an example of fracture, screws in, CT scan, looking good, screws out, motion preserved. And not just axial flexion extension, they took it a step further and they did CT scans, and they compared the CT scan to those patients that got anterior screws versus posterior temporary fixation. And normal C1-2 rotation is somewhere around 40 degrees by Dvorak and Monkberg. And in their study with the anterior screw, they had 40 degrees. They lost a little with the posterior temporary fixation and probably some scarring around the joint, but still pretty good unilateral rotation of 30 degrees. So, but could this work in elderly patients? In one series, they reported only a third of their elderly patients really healed the fracture. But when I look at mine, and I have all those CT scans on everybody, 73% healed the fracture, these older patients. And so that's an interesting observation. And here's Denise. Denise healed her fracture. So even with that initial diastasis, it healed. So that's led me to change my thinking now, and this is where I'm going. So here's a patient I had, 74-year-old mountain biker, pretty vigorous guy, goes over the handlebar, has a fracture, but he's an active guy, and he gets put in a collar, and he wears this collar for 5 months. And sorry. And he has severe pain, he's not happy, and I end up seeing him. And here's what we have, and we see flexion extension, instability, and here's the CT scan. So non-union, 5 months out. And so I put screws in him, and I also put in my dorsal C1-2 graft, but that's an easy thing to remove. And so then I got a CT scan at 3 months and said, well, it looks like this thing's on its way to healing. And so, despite his age, he looks like he's healing. I took him back. I took out my graft. I cut my cables. I took off my screws. Now, I got to admit, I was a little bit leery of taking out the 1 screws because if it didn't work, I didn't want to have to go stick them back in. But he moves. He's happy. He doesn't have pain, and I think that that this is where things are headed in the future. And I plan to do this on most of my patients, because I think with temporary fixation, I can avoid the problems of an anterior screw. And with temporary fixation, I still get, if the fracture heals, it's easy enough to take out. And I think that this will be another step forward for them. And so I feel that the posterior fusion morbidity and mortality is acceptable. I have my group of patients. It's a small number, but my mortality is in line with what the published mortality is in these large databases looking at odontoid fractures with surgery. And so I don't think that, since I'm not selecting any patients, I think that's the true number. And I think that we can get people up and going much quicker. I think the dysphagia non-union rates are less with posterior fixation than the other. I only use C1-2 translaminar if there's no other option. And in fact, if I really can't put in the bicortical screws with the translaminar technique, I'll put a screw in C3. I'll go down another level, because I think to lose that little bit of motion is better than to take the patient back for redo. And as I said, I consider temporary fixation. With that, I thank you for your attention. I'd be happy to answer any questions.
Hey, Vince, this is Dan. Thanks so much for an outstanding lecture as usual. You mentioned that when you take the ganglion, you get more bleeding than when you don't. And I saw that when you were doing the C1-2 intraarticular fusion, you had taken the ganglion. How often do you routinely take, do you routinely take the C2 nerve root, or do you leave it alone most of the time?
I only take it if I'm going to access the joint, put those grafts in. And I'm always preganglionic, so I haven't had a pain issue with it. I know there are some surgeons that feel like they can get into the joint pretty well without taking the root. I haven't really tried that because I really put some big grafts in this joint, and but that's the time I take it. Otherwise, I don't see a need to take it. I don't know what your techniques are. What, do you take it?
No, I don't routinely take it, and I agree that if you take it post-ganglionic, you can get significant symptoms. I had one of my former fellows do a prospective study of taking it versus not, because he would routinely take it, and he said that there was no problem with taking it. Then when he did the study and got patient-reported outcomes, he found that a substantial percentage of patients actually complained about it, said they didn't like the numbness. Some had dysesthesia, and so he stopped routinely taking it. But it certainly makes it a lot easier to do a C1-2 fusion if you remove it and just basically cauterize all of the veins.
You can see the bony anatomy better. There's no question.
Yeah. And then I still treat the octogenarians and older, and even some 70-year-olds with non-operative treatment, and I just give them a soft collar for comfort. If they look like they are only going to live another 5 to 10 years, I still treat them non-operatively, knowing that they're going to get a non-union, and leave them alone. But I agree. If you're an active 70-year-old, I had an active 70-year-old. I did exactly what you mentioned, putting in C1 lateral mass. Beltran Harms described that as their original technique for C1 lateral mass C2 pedicle screws, of treating it like that and then taking out everything once they're fused in at the odontoid level. So I think that's a great technique.
Hey, Vince, it's Roger. Great presentation. And now in terms of non-operative treatment, the problem is that there's just no endpoint. I mean, you talked about the stable, not the union, but the stable situation where you have like a fibrous union maybe. The problem is it's impossible to prove, it's impossible to disprove. So you basically end up with all these follow-up visits and discussions with the family, should you take the collar off? So I think unless you really have a very strong policy in place where everybody agrees, I think I completely agree with your decision to operate on these patients because there's just no endpoint, you know? And that's certainly what we've seen. Then we follow these patients for months and then you end up operating anyway because they're just, you know, nobody's comfortable really taking the collar off or keeping the collar on forever.
I agree. I think that if you're up to speed in doing these, the morbidity is not that great. And I think it's kind of, you're right, you have to have an endpoint. It's sort of like a re-exploring a wound. I've never regretted it, but if every day you go, well, should I go back and look? Should I not? You should just call the question and do it. And that's how I approach these people. I want them out of bed. I don't want DVTs. I don't want pneumonia. And I think that despite, I wasn't at this section, if any of you were there when they had this debate, but I understand John Herbert was presenting a great case for no surgery, but I just feel like that's out of step with what's happening in this country, at least. And I think to just do it and you're done. You have your endpoint and you get on with your life. So.
And I was happy to see your results on the C1, C2 cages. We just published a case series of patients where we use these commercially available Geriatric cages. Mm-hmm. But I think you could use any allograft, obviously cage that you have available at the appropriate size to put it into C1, C2. So I was happy to see that. I had a question about the transarticular screws. When I trained with Sontag and Dickman and Phoenix, we did a lot of transarticular screws, obviously. And then over the course of the fellowship and then afterwards, I really shifted towards the C1, C2 screw fixation. I was just always worried about the anatomy. I mean, Sontag said, and you mentioned also, there's about a 20% chance of the vertebral artery not being an ideal position for transarticular screw fixation. In reality, if you really look at the imaging, though, it seems to be much higher to me. So I shifted really to 100% during the C1, C2 fixation. And you talked about both. I'm just wondering, over the years, have you seen the same kind of shifting in your practice? And if you use the transarticular screws, though, what instrumentation system do you use for that?
So I have shifted away from it myself. I still do it if I have a nice channel of bone. I think part of my reason to do it is so the residents see one now and then, to be honest. And I just use there's a Medtronic straight screw that came with their UCSS kit. So if I do it, I use that. I normally don't use K-wires and cannulated drills to do it. I do a lot of drilling by hand. Once I get the start hole, I drill the pars if I'm going to do transarticular by hand because I feel like I stay in that cancellous bone, I kind of steer it down there. And then once it gets firm, if you shoot a fluoro shot, you're at the joint, now you're past the root. So then I hook it to power and power past the joint. But I've shifted away from it by and large, as you have.
All right, thanks.
Hey, Dr. Traynelis, Mike Verk, great update on the state of odontoid fractures. Just a quick question about bone grafting. So you're taking rib. How do you think that compares to fresh frozen iliac crest? Using that there, we have that available, and I use it quite a bit. And then also, if C1 is not available due to fracture or otherwise, aside from the C1-2 allograft wafers that you're putting in there, do you use anything else in the posterior lateral space to achieve posterior fusion?
Yeah, I'll put some extra bone, usually autograft, in above that allograft that I pounded into the joint. I don't use a lot of BMP here. I think, I'm old enough, you think back in the years ago, decades ago, like we would never use allograft as an onlay graft. Never work. You would never do that. It always would be autograft. And now there's more and more people that use it. And it could be that the rigidity of the screw fixation is making it work when it didn't work when we did other things. So maybe it does work, but I still firmly believe in autograft for posterior fusions, and I think I get it right below the scapula. I can get the rib out and the wound closed before the neck is exposed by the fellow. It's fast, it's simple, so I'm a big fan of it. But I realize I'm a dinosaur. I'm an outlier with this.
Right. Thanks.
Vince, are you using the same facet grafts that you were using for fusions at the subaxial levels?
They're similar but bigger. They're 10 by 12, and then heights of 4, 5, 6. And if you really have basilar invagination and you're working in that space to reduce it, then you can shift over to the small cervical cages, because the smaller cages are, some of them are 11 by 11, so you can easily fit that into that space, and then you can get more height out of it. But I use they are bigger but similar to the subaxial allografts I use. I have some little paddles that I can put in to distract it, and they're very helpful, especially again if you use it for basilar invagination reduction.
If you use it for basilar invagination, how do you know what's your endpoint? How do you know whether that putting those cages is enough, or you still have to do something else?
So as you distract them, I'll have fluoro, but it takes a couple O-arm spins, because some things can happen. As you distract them, you're going to correct your basilar invagination, but there can be an AP translation as well. And so as you distract them, then you might have to put purchase in the occiput and compress between the occiput and C1 to try to reduce this AP translation. And if you can't get it reduced, and then you can put bigger spacers in, you kind of change your fulcrum and you get more power. And so it's a combination of how tall to make them, and also make sure that the C1-2 clivus alignment is normal. And that may require some compression between the occiput and C2. And what I do is it's O-arm spins, because then when you get to where you want, or you realize you're just not going to get any better, then you reach your end point. And it is curious that if you put in like a 9mm distractor, it seems like when you really measure it, you gain 15 millimeters. It seemed, I can't figure it out. It seemed what you put in there, and then what you later measure, how much you reduce the invagination, it seems like you get more bang than what you put in. But I think it's a great technique. I think it gets rid of, we don't see that many need for transorals anyway, but it gets rid of most of them, I think. So I like it.
Sounds great. Well, I think any other questions or comments?
And so you operate on some of these guys. You don't. And Dan, you send some away. You operate on some. How about you, Roger? You do them all?
Well, it's really complicated, because the tendency, if these patients come in, is always, let's put them in the car. I mean, depending on the severity of the fracture and the circumstances, but frequently, we had a case the other day that was a C1 fracture, a very discrepant C1 Jefferson fracture, and so not a C2 fracture, just as an example. So we all, we discussed it in the group, and they said, well, let's just watch him, it's going to be fine. And then he comes back, 6 weeks later, and the CT scan looks exactly the same, and he's still in the collar. So I end up actually today I'm taking it to the OR. So there's just no endpoint. The problem is that, unless you make a policy that you're just comfortable taking these patients out of the collar, regardless of what the CT scan looks like, there's just no real endpoint. And therefore, I mean, I think I'm more aggressive operating now than I used to be in the beginning. But then there are always cases where you kind of discuss it, you know?
Yeah. Well, I see what I see as my future is I'm shifting to try to do temporary fixation in all these people, and we'll see where that goes. That's my new thing.
But if I saw that correct, you know, the last case you showed, you had a C1, C2 fusion, correct?
He did, but I took it down. I just put a piece of autograft in there, and yeah.
But then
Well, I can just take out this autograft that's right here, cut the cable. I didn't do anything in the joints. I didn't take the root. I didn't do anything else. So I can just take this out and disconnect my screws.
oh, so you took that out.
Let me,
Yeah,
excuse me 1 second. I have a case starting. They're screaming at me. Just 1 second. Hello? Yeah, I'm on a Zoom thing now. Patients in the room? They're in the room? Okay, all right, thanks. Bye-bye. Sorry about that.
So I guess we'll let you go, Vince. We're starting now as well here, so.
All right, well, again, thank you very much. It was a pleasure to talk to you. Big honor, so thanks.
Be well, everyone. Thank you.
Thank you
Thanks.
so much.
Have a good week.
Yep.